Good morning, everyone. Thank you so much for being here today. We are very pleased to invite my old friend Patrick Yu and Zhong Yong professor and Professor Libin Jiang. We are talking about liver history optic neuropathy. Welcome.
Hi, Patrick. Nice to meet you again. We all know you are the kind of pioneer in research on the LHON for a long time. So why would you so many interest in this kind of a specific area of LHON?
Right, very pleased to meet all of you. It's great to be here and meet you in person after such a long time. I've become very interested in this area of mitochondrial genetics since I was a medical student. I had the chance to do a project on Leber's optic neuropathy, LHON, and that was more than 20 years ago. And since then, I've become much more interested in how we could potentially improve the visual outcome for patients who are unfortunate to be affected with this mitochondrial form of blindness. Because as we all know, because we are practicing neuro-ophthalmologists, we see patients coming to clinic, they've been affected, they've lost a lot of vision, and unfortunately at the moment there's not that much that we can offer them in terms of disease-modifying treatment. So that's been the main driver for me, to better understand what causes the loss of retinal ganglion cells in this condition, and hopefully a better understanding of the mechanisms involved will allow us to develop better treatment which will improve the visual prognosis. And I think we made a lot of progress over the past 10 years, and I suspect the next 10 years we'll see even more being made, especially in the field of gene therapy.
So thank you very much for your effort for a long time. So, we always say, so far we don't have the product in commercial marketing, for treatment in the patient with LHON. So what's your experiences and expectation for the future gene therapy for this kind of disease?
Right. And I think that's an important point that you've raised, is a lot of the preclinical work takes time, because fundamentally we need to be sure that any gene therapy treatment that we're using is safe, because we don't want to make matters worse for the people who already have lost a lot of vision. And once you've done the preclinical work, then you need to do phase 1 study in patients who've been affected to look again at safety, and then larger phase 3 clinical trials to determine whether or not the treatment is working or not. So in the context of, for example, the gene therapy trials that have been run by GenSci Biologics for GS10, now there have been 3 phase 3 clinical trials that have been conducted and published in journals in the published literature. And the evidence is promising, showing that there is an improvement in vision in patients who are treated with GS10. And now the next step is to present the data to the regulators, whether it's the European Medicines Agency or whether it's the FDA in the US, and then they will make a decision based on the data that you've been providing, whether or not there is sufficient evidence to approve the drug for marketing in the countries which are covered by these regulatory agencies. So to your question, that's correct. At the moment, gene therapy remains an experimental treatment, which is being conducted as part of clinical trials or compassionate use programs. I think we need to wait and see whether the regulators will approve the medication. And then after the medication has been approved, the next step, individual countries will need to approve the reimbursement, which is another step which can be quite challenging and takes time to resolve.
Thank you. So talk about gene stem. That's a little bit early clinical trials in Europe, right? You are leading PI for those kind of the clinical trials. So what's your suggestion for some ongoing gene therapy clinical trial here in China or worldwide? It's a kind of same therapy method. There's a difference between those different kind of clinical trials?
Yes, at the moment, the gene therapy programs for Leber's optic neuropathy are focused on the 11.778 mutation, which affects the ND4 gene. And this is the most common cause of Leber's optic neuropathy. In the Caucasian population, that this accounts for 60 to 70% of cases, but here in China, probably around 90% of patients have the 11.778 mutation. It's much more common here. And there have been a number of programs So there is the program which has been led by GenSci Biologics, but there is also the late Dr. John Guy, who also initiated a gene therapy program for ND4 at Bascom Palmer, and also the work from Professor Libin from Wuhan, where again they are using the same principle of allotopic gene expression to insert the ND4 construct into the mitochondria. So all three gene therapy programs have looked at the same patient population with the 11.778 mutation, but they've done it at different stages. The one which is the most advanced are the phase 3 clinical trials, which have been sponsored by GenSci Biologics. I think it's quite clear that there are still a lot of questions that we need to answer. The majority of the patients have lost vision for less than 1 year. So now we need to look more into the chronic group. So are patients who've been affected for more than 1 year also going to benefit from gene therapy? So what is the therapeutic window? Because it's quite clear that 1 year is just an artificial boundary, and that it is likely that if you have the disease for more than 1 year, you're also going to benefit, but perhaps less than if you're treated a bit earlier. The other thing as well that we need to investigate further is, do we inject the gene therapy vector in one eye, or do we inject it in both eyes? And again, these are part of future clinical trials that need to be done. So to your question, obviously in China you have a big population, you have a lot of people who've been affected with Leber's optic neuropathy. For example, in Beijing, you have a lot of experience of seeing patients with these mitochondrial genetic disorders. And what was very clear from all the trials that have been done so far is that we need to have these multi-center, multinational collaborations. So I think having Chinese centers recruiting patients for LHON, whether in Beijing, Shanghai, or Guangzhou, I think will also be very relevant for future studies. So I'm hoping that this will be something that will become more of a reality, for these next phases of the programs, whether led by GenSci or by neuro-op or by any other companies who are interested in developing treatment for this condition.
Yeah, very good. Thank you very much for your wonderful suggestion. And one more question. So is there a ratio difference between the Europe or China, different kind of racial difference with this kind of disease?
Mm-hmm. So I think this is a very good question, because sometimes there are quite marked differences based on the ethnic group. The one difference that we know is that, for example, in terms of the distribution of the genetic mutation that causes Leber's optic neuropathy, as I've mentioned already before, in white Caucasian populations, you have 3 common mutations. You have the 11.778, 3.4.6.1, and 14.4.84, and 11.778 accounts for around 60 to 70% of cases. But when you look at Asia, when you look at the Chinese population, the Japanese population, 11.770 is much more common, more like 90%. So 3.4.6.0 and 14.4.84, from what I've been told by Professor Wei and other experts in China, is the most 11.770 is the most common one. 3.4.6.0 and 14.4.84 is much rarer.
Yeah.
But in terms of the clinical presentation of Leber's optic neuropathy, I don't think there is any big difference whether or not you come from specific ethnic groups. In all of these populations, it presents in the same way, with very rapidly progressive visual loss affecting one eye or both eyes at onset, and then becoming bilateral, after a period of 3 to 6 months. So I think the clinical features are the same. Very rapid, severe loss of vision, eventually both eyes are affected, and unfortunately poor visual prognosis.
Okay, thank you very much.
Hi, Patrick. My name is Libin Jiang from Beijing Tong Hospital. Nice to meet you. I have a question. A very interesting contralateral effect in LHON and gene therapy had been observed. What is the mechanism? I don't know. One question. And the phenomena observed in other studies. Okay. Sure. Thank you.
So
it's very interesting.
Correct, correct. And as you mentioned, this is interesting and very unexpected. So when, for example, the rescue and reverse trials were being designed, the aim was to inject one eye with a gene therapy vector intravitreally, and then the other eye was a sham injection. And we thought this was a very smart idea, where the uninjected eye was a good internal control. But what we saw as part of rescue and reverse was the fact that you had a bilateral improvement in vision, irrespective of whether or not you had the injection or not had the injection. So there are a number of possible explanations for this, right? One possible explanation is essentially that there has been a transfer of the gene therapy vector from the injected eye to the uninjected eye. And to explore that further, there have been a non-human primate study where the monkeys were injected in one eye and then the animals were sacrificed. And based on these non-human primate studies, when you basically look at the tissues from the eye, the retina, the optic nerve, chiasm, back into the occipital cortex, there was evidence that there was transfer of the gene therapy vector, to the contralateral optic nerve and to the contralateral optic chiasm. So there is evidence to suggest there has been some form of transfer. There has also been a more recent piece of evidence coming from post-mortem studies where one patient with Leber's optic neuropathy who was recruited into the GenSight trials died for unrelated reason, and they had access to the eyes post-mortem. The results have been presented at recent meetings by the group of Valerio Carelli and Professor Alfredo Seydun. And again, as they saw in the non-human primate studies, they found evidence of viral vector DNA in the contralateral non-injected eye, but the concentration of the gene therapy vector was much lower. So 1 out of 200 of the concentration that you found in the injected eye. So quite a lower concentration. And the key question is whether or not this is sufficient to account for the bilateral improvement. Another explanation that could also be relevant is whether or not, as you're injecting the gene therapy vector in one eye, the actual injection and the actual production of the local protein might be inducing, for example, some subclinical inflammation, production of some mediators that could be promoting mitochondrial biogenesis, and these mediators are the ones which are being transferred to the other eye. So all of these are hypotheses, right? And we do not yet have a clear, definite answer to this. And obviously we need to understand this principle more because this is relevant to the way that we design future clinical trials for Leber's optic neuropathy and for other inherited optic neuropathies. So as Professor Wei mentioned, this is very interesting, still very mysterious, and I think we need more work to look into that further.
Just like the anti-VEGF drugs, injection in the eye. So, is there any possibility of the oxygen flow, retroaxin flow through the CSF pathway to go to the other eyes? Maybe I just guess.
We can. The good thing that we do as scientists is that we speculate, right? And I think this bilateral improvement with the gene therapy vector was also observed by the work done by Dr. John Gad, Basco and Palmer, and also by the group of Professor Libin. As you mentioned, that there has been evidence when you inject anti-VEGF agents in one eye, you're also getting the effect in the other one. But here, it's a bit more easy to understand in the sense that the anti-VEGF factor is probably being transferred to the vascular system, right? But in terms of a gene therapy vector being transferred to the other eye, I think there's much more limited evidence, right? And I think essentially that's part of being the first people doing work in a certain area. You design the clinical trial with all the best intentions, but when the results come, they are unexpected results, and then you have to go back to the drawing board and design the next study taking that into consideration. So for example, now, if you're going to be designing a gene therapy trial for Leber's optic neuropathy, you're definitely going to have a control arm where people are not getting the gene therapy vector so that you can compare and make much more reliable conclusion.
Yeah.
Oh, a question. Adolescent had been approved by EMA, but approved by China, Japan, or American. Do you have experience of this medicine for treat the LHON? Okay.
So as you mentioned, even before there was gene therapy, nearly 15 years ago, a number of studies were initiated looking at whether idebenone would be beneficial for patients with Leber's optic neuropathy. So there was a randomized controlled trial known as RODOS, but this was for a short period of time, for 6 months. And RODOS did show that people who were treated by idebenone had a higher likelihood of getting some visual improvement. After RODOS, there was an expanded access program, and more recently was LEROS. So to cut a long story short, back in 2015, the European Medicines Agency approved idebenone Raxone for use in patients with Leber's optic neuropathy. And then after that, a number of countries approved and provided reimbursement for Raxone. But this is not the case for all European countries. Certainly, if you have a patient with Leber's optic neuropathy and you have access to the medication, it would be highly beneficial for them to be started on idebenone, because a proportion of patients will get some visual benefit. Having said that, probably half of the patients will not get any benefit from idebenone, and that's the reason why the gene therapy programs came along, to try and improve the options that we have to improve the visual prognosis for these patients. In terms of what happens in other parts of the world, certainly in North America, in Asia, there are a lot of people who are being treated with idebenone, but not with Raxone, but from generic forms of idebenone that they are purchasing from various sources, right? All three of you practice in China, so I suspect a lot of your patients will be taking idebenone, but getting it from other sources of supply. In terms of where we move from here, there's no reason why in the future, if we have idebenone and we have gene therapy, that the patient could not be treated with both, because they are complementary, they are acting through different mechanisms, and potentially, having both treatment might result in a better outcome. But we don't know that, but we can speculate that this might be the case.
Do you have a sense of what type of patients more able to benefit from the gene therapy?
And again, this is a question where we can provide some answers, but not all the answers. So most of the gene therapy programs for the 11.778 mutation have recruited patients with disease duration of up to 1 year, because the thought at the time was if you treat earlier, it's better, right? So, and again, I think there are some interesting observations, some surprises. Clearly, we need to look into that further, but there is some suggestion that, if you treat someone between 6 and 12 months, compared with less than 6 months, that the group between 6 and 12 months seem to do a bit better, right? So again, this is based on subgroup analysis, but clearly, if you treat within 1 year, that seems to be helping in terms of visual improvement. There is also evidence from the data produced by the group of Professor Libin and also by the compassionate use program being run by Genzyme Biologics, that if you treat patients who had disease for longer, for more than 1 year, they can also benefit, right? But we still need to do further studies to look at this therapeutic window. How far into the disease can you still benefit? 3 years, 5 years, 10 years? And if you treat later into the chronic phase, at which point does it not make such a big difference in terms of the benefits? So we don't have all the answers, and I think that's what other studies we need to explore in terms of how far into the disease process can you still have a therapeutic benefit with whatever treatment it might be, right? If you look at the story with idebenone, for some time we thought that you had to treat patients with disease duration of up to 1 year. But the more recent LEROS study suggests quite clearly that if you treat patients with LHON who've been affected for up to 5 years, they can also do well, right? So I think the therapeutic window is probably wider than we thought initially.
So the early and the longer is better, right? When you treatment the early and the longer.
Yes, and
That's really better, right?
certainly for idebenone, you have to give the treatment for a decent period of time. So roughly speaking, if you give idebenone for about a year, around 30 to 35% of people will benefit. But if you treat for longer, for 2 years, then the group of people who respond will probably increase to around 45%, right? But after 2 years of treatment with idebenone, there is a plateau. So at least from the idebenone point of view, if you treat for up to 2 years, you've given your patient the best chance of getting the improvement, right? Gene therapy, I think, again, we need to look into the chronic group a bit more, but I suspect that, there is going to be a group of people in the chronic group, perhaps up to 3 years or up to 5 years, where treatment would still be worthwhile. But this is just a speculation from my point of view.
As the international leader in the LHON, do you have advice whether or when the international guideline should be developed?
So this is very important because Leber's optic neuropathy is a relatively rare disease, and it's very useful for clinicians, especially people who don't see a lot of patients with Leber's optic neuropathy, to have guidance about how to diagnose the condition, manage the condition, and treatment as well. So Professor Carelli led a consensus group back in 2016, and the consensus guideline was published in the Journal of Neuro-Ophthalmology in 2017. But that is more than 6 years ago now, right? And a lot of things have changed since then in terms of our knowledge of the genetic basis of Leber's optic neuropathy, and in terms of how we manage this condition, including idebenone, including gene therapy. So we're hoping that there will be under consensus, and I think it will be very important to include experts from across the world, from Europe, North America, China, and Asia, because in the end, there are some slight variation in practice, and we need to reflect that in the consensus. So, whether the consensus will be in 2024 or afterwards, we don't know. But I think that is certainly something that we're all thinking about, that we need to have a revised consensus statement about how we diagnose, manage this condition, and also plan in terms of future clinical trials and treatment paradigms.
Thank you very much. We have one more last question. So we all have activated the LHON ND1 phase 1 and phase 2 clinical start. So to have any clinical experiences and research experiences about this kind of the ND1, and is there a difference between those two? ND1 is much greater than the LHON ND4, is that right? There is a difference clinical. Whatever, they have a difference between those?
Sure. So I think it's very exciting that now there is a second gene therapy program for LHON, which is essentially looking at the ND1 346 mutation. And this is very much coming from the work of Professor Libin and his group. And there is now early phase clinical trials which have been launched by Europe, in China, and also in the United States. These are early phase, looking at safety, but hopefully all being well, this will lead on to larger phase 3 clinical trials involving multiple centers. To your question about the differences between all these mutations that cause Leber's optic neuropathy, we've talked already about the fact that 3460 is much rarer, even much more rare in Asia. But we do know that in both 3460 and 11778, unfortunately, the visual prognosis is not very good because the rate of spontaneous visual recovery is low, and almost all of these patients will retain quite a dense central scotoma and will remain significantly visually impaired for the rest of their lives. That's the reason why it's important to develop a gene therapy program for this mutation. Certainly, that from a biochemical perspective, when they look at 3460, 11778, and 14484, the 3460 mutation has a much more severe impact on mitochondrial function. So to some extent, this seems to be biochemically the worst mutation to have, right? But compared with the 11778 mutation, we don't have as much clinical data because this is a rarer group of patients. And perhaps what we need to do is, we need to collect more clinical information on the 3460 mutation, collecting data from across the world, because only by doing this will we have a large enough cohort to be able to do much more sophisticated subgroup analysis, right? But I think the landscape is changing, right? The clinical trials for LHON started with idebenone, and then we move into the 11778 ND4 gene therapy program. Now we have the 3460 ND1 program, and I think there will be other exciting gene therapy programs being launched, not only for Leber's optic neuropathy, but for other inherited optic neuropathies like OPA1, autosomal dominant optic atrophy. So we still need to be cautious. These remain experimental treatments, but I think for us clinicians and for patients and families coming to our clinic, I think this is a great source of hope in the sense that they can realize that there's a lot of research being done, there's progress being made, and that gives them something to look forward in terms of the future, because these are inherited conditions. So in one generation there might be other children being affected in the future, and it helps for us in terms of keeping up morale, that they know that there are clinical studies that will be recruiting, and hopefully these will lead to breakthroughs in terms of successful and effective treatment.
Thank you very much. Thank you.
I understand we have a lot of problem and difficult, but finally, ultimately, it all comes down to quality. Good wine will always sell itself, and it has become particularly true in today's internet shopping age. Yeah, thank you.
Yeah.
Thank you.
Thank you very much.
So thank you very much for inviting me to take part in this interview, and I think the fact that we're all here shows about how well these international collaborations are working. And I've known Professor Wei now for nearly 12 years, and it's good that now 12 years later we're making progress in this area of research, really, right? Thank you very much.
Thank you very much. Thank